Good evening, all. Superbugs are challenge nowadays for any medical and surgical disease. We are getting more and more antibiotic resistance in our armamentarium of antibiotics. So, how to deal with this challenge? Chess Council of India has come up with a brilliant idea to have all the stalwarts practicing to discuss on this very important topic, combating antibiotic resistance, role of effective stewardship program. So I invite my galaxy of esteemed panelists, Dr. Nitin Abhyankar, from a renowned chess specialist from Pune, Dr. Komal Shah, a renowned chess specialist and ID specialist from Nasik. She had her thesis on this particular topic on AMS. Dr. Abhishek Tandon from Lucknow, Dr. Laxmi Murali from Chennai, Dr. Rajkumar Jupally from Hyderabad. So we will be starting initially with two very important talks. The first talk would be from Dr. Rajkumar Jupally on diagnostic AMS. It will be followed by Dr. Komal Shah on therapeutic AMS. Dr. Rajkumar.
Good evening, everyone. Today we will be discussing regarding the diagnostic stewardship usage in critical care that would be a part of our antimicrobial stewardship. Thank you, Dr. Vijay Kumar sir, for giving me this opportunity, and thank you, Dr. Ankit, for the introduction. Before we proceed with the main topic of diagnostic stewardship, I would like to bring your attention to one of the quote of Sir William Osler, who mentioned as medicine is a science of uncertainty and it's also an art of probability. Usually, most of us have a misconception that results of diagnostic tests undoubtedly determine the presence or absence of disease. Like most of us who's working in ICUs in the major like critical care and pulmonology would not accept to this. Okay, so usually there will be false positive results and false negative results. So this misconception has to go. And second thing, diagnostic stewardship has emerged to improve the clinical care of the patients with fewer positive test results, false positive test results, and less overdiagnosing a condition, while in the same place identifying the true positive cases also. The main usage of diagnostic stewardship is to decrease the inappropriate testing, like sending an inappropriate test to the patient, which doesn't yield any positive result and which doesn't help in treating the patient. Okay, so it is mainly to decrease the inappropriate testing. Also, it helps in rapid identification of bacteria if a blood culture turns out to be positive, so that we can intervene at a faster rate and give an appropriate antibiotic to treat the patient. The objective of a diagnostic stewardship is to improve the patient care and outcomes, avoiding patient harm by inappropriate antimicrobial use and giving for more days, okay, and inappropriate choice of antibiotics also. So it helps in optimizing the antimicrobial use, improving the efficiency of care, and improve the institutional cost and metrics also. So it decreases the cost to the patient also. So thereby diagnostic stewardship is one of the most important thing you have to follow in ICU. The basic thing, whenever a patient presents to you to your ICU or clinic, so you have to take a thorough history from the patient as well as patient attenders and do a thorough clinical examination. The focused clinical examination will help you in choosing a right test at a right time. So diagnostic stewardship is nothing but, in brief, you are choosing a right test to a right patient at a right time. Okay, so after sending the test, if needed, we can do a rapid diagnostic test also. Like we do if a patient comes with an upper respiratory symptoms and a lower respiratory symptoms, we send a panel which detects the appropriate DNA and RNA and will give an appropriate test so that we can treat it at a faster pace. And once the results are available, there comes the role of antimicrobial stewardship. The reports are interpreted by the clinician, and the clinician will start the appropriate antibiotic at an appropriate time. Thereby, the patient will get treated in a better way. The question comes, the right test. So before sending the test, you need to look into the sensitivity and specificity of that particular test, the positive predictive value and negative predictive value of that test, the testing volumes of the lab, as well as laboratory feasibility and the cost effectiveness of that particular test. Will the clinical care of the patient be affected by the test results also needs to be considered before sending the test, and will the result will be available in time to optimally affect the care. So that also needs to be considered. Suppose if you're sending a test which doesn't come within, if it comes after 1 to 2 weeks, then you cannot treat the patient in an immediate pace with that test. You need to send that test, but you cannot wait for the test results to treat the patient. Okay, so consider the right time also whenever you are sending the test. In antimicrobial stewardship, you know these 3 points, like right interpretation of the lab values, the right interpretation of the culture sensitivity report. Based on that, you need to start a right antimicrobial at a right time to have an optimal outcome in the patient. The core principles of diagnostic stewardship include, you can divide it into three phases. The pre-analytic phase, that is before testing the sending the test, the analytic phase, and the post-analytic phase. So diagnostic stewardship principle stands on ordering the right test, that is the right time at right time for the right patient, understanding the test and the pre-test probability, whether this test can diagnose the clinical condition appropriately or not, should also be considered. In the pre-analytic phase, what we are concentrating more on is the specimen collection, whether the quality of sample is adequate or not. Suppose if you're sending a sputum sample, whether the sputum sample quality is adequate or not, whether there are more epithelial cells. Okay, so this kind of specimen collection also you need to concentrate to get an appropriate result. The transport should be you should minimize the contamination during the transport from your unit to the lab. You should minimize the contamination in the sample, and the pre-test probability, as we discussed, whether this test will yield a positive result to treat the patient appropriately or not. In the analytic stage, you need to look into whether the molecular based rapid test, whether this NAT or next gen sequencing will help you in early identification of the causative organism. So this you need to look into. Whenever there is an appropriate situation, you need to proceed, because we will get the result early and you can treat the patient early so that the patient will have a good outcome. And the reflex testing, that is the urine. Suppose if you are sending a sample for urine, if the lab will process for the urine culture only if suppose the number of WBCs are more than 10. Okay, so such kind of reflex testing, if you are following in your lab, then it would be definitely helpful in decreasing the number of culture processing in your lab. The post-analytic phasing, you will be communicating, the microbiologist will be communicating the results in a timely and accurate manner to the clinician. And post results, the clinician will decide which antibiotic to start and for how many days. And every time you should evaluate, whenever you're following this diagnostic stewardship, you should evaluate and adjust your diagnostic stewardship's plan over a period of time. Okay, so you should audit your diagnostic stewardship plan, whether it is helping you out in treating the patient or whether it is increasing the burden on the clinician as well as the microbiologist. So always you should do the audit, regular audits on this diagnostic stewardships also. In this slide, I would like to draw your attention to test ordering. So if you look into the fourth point, you should always see that you should reduce the easy by increased access to this test in electronic health record. Suppose if you are ordering some test, like you order some antibiotic, you need to fill a justification form why you are ordering these antibiotics. In the same way, when you are ordering a test, you need to think whether this test is needed for the patient or not. And from the antimicrobial stewardship program, you should encourage that some tests there should be reduced access to the test, and some tests it should be easily available in the electronic health records. This is the main important slide in our discussion today. Sorry, it is little clumsy, but I'll try to draw your attention to each one of it. So if you're planning to send a blood culture, okay, if you're planning to send a blood culture, look into this. Before ordering the test, you need to look into why I need to send this blood culture. Whether I would be able to identify bacteria by sending the blood culture or not, you should see. Like isolated fever in a non-septic patients, like a post-trauma, you will expect there will be a fever spikes. By sending culture in such patients, you will not yield anything. Okay, so before ordering a test, you need to think on it. And the collection of blood culture sample is also very important. Okay, so you should educate your nurse how to collect the sample. And reporting, while reporting, report gram stain results, which are available early. Provide link to antibiogram with the pathogen ID. Highly resistant organisms should be reported. Okay, so in such way you can interpret it in a better way. The same with respiratory cultures. Okay, so do not order for non-severe caps. Okay, so do not routinely order a sputum culture. Do not process sputum culture if there are greater than 10 squamous epithelial cells. Okay, per low power field. So if you order, there will be more of contamination from the oral bacteria. And pneumonia multiplex panel also. Okay, do not process if there are greater than 10 squamous epithelial cells, and use a structured comments to help in interpreting the test results. Skin and soft tissue infections, especially this is more particular in surgical ICUs. You should not send the wound swabs from the superficial surgical site. Even if there is a signs of infection, try to send a deep swab so that it will avoid the contamination of the sample. Urine culture, this is one of the most important thing. Avoid testing in non-specific clinical syndromes. Like if you see a patient who is drowsy, you think that he has a sepsis, and most of you point out towards the urine as the source of sepsis. No, it is not always true. So always have a pre-test probability whether this test would help before sending the urine culture. And don't collect the urine from the catheter bag. Most of the nurses will do it, but you as an intensivist should educate your nurses not to collect urine from the culture bag. Same with the fungal diagnostic test. Do not routinely send the biomarkers for the identification without knowing the false positivities of these biomarkers. As we discussed, UTI is the most commonly diagnosed clinical condition, and it is also most inappropriately diagnosed condition also. Okay, so most of the inappropriate antibiotics usage goes with the urinary tract infection. Differentiation of urinary tract infection from an asymptomatic bacteriuria always remains a clinical challenge. In some clinical condition, you need to treat asymptomatic bacteriuria, like in pregnant patients and before proceeding with urological surgeries. There you need to consider an option of doing a culture in such scenarios. In lower respiratory tract infection, viral pathogen, most of now we have a season of influenza. So inappropriate use of antimicrobials can be cut short if you send a proper assay like panel to know the identify the influenza virus, influenza A, B. So if you can identify this viral infection early, then you can cut down on the usage of antimicrobial. And most importantly thing, if the patient is tracheostomized, the patient is having fever, even if due to non-infectious cause, you will send a culture, especially the endotracheal sample. You might grow the colonizer also, because usually the tracheostomized patient, there is high chance that of the colonizer. So based on the colonizer, if you treat the patient, then it will lead to inappropriate usage of antibiotics and increased stay in the hospital, and it will increase the cost to the patient as well. The National Healthcare Safety Network in USA, the CDC, these are the examples of few diagnostic stewardship strategies, like we have discussed already in detail regarding this QATI, hospital onset Clostridium difficile, and CLABSI. I would like to draw your attention to hospital onset Clostridium difficile. Most of our hospital patients are on laxatives. Okay, usually on patient on laxative, you expect that the patient will have loose stools. Okay, so before sending the sample, the stool sample for the lab, you should look into whether this patient is on laxative, and you should also look into the Bristol stool grading also. Okay, do not test formed stools. Only if it is a very watery stool, send the sample for a hospital onset Clostridium difficile infection. In the same way, CLABSI, what we have discussed is, you have to be very attentive in what way the nursing staff is collecting the samples. Okay, so thereby you can decrease the risk of contamination. So by implementing the diagnostic stewardship program, so what you are achieving? Okay, so there are different kinds of studies and reporting being done on this. If you can see here, first with the COTI infections, if they have followed up what they have done. So, okay, so the best practice alert to avoid culture for asymptomatic bacteriuria, by following this, they have observed 6.3% decrease in cultures being sent to the lab and 0.5% decrease in antibiotic usage. The Keller et al. Have observed this. And Murali in 2017, what they have observed is they have observed the reported hospital-acquired infection rate. And if you do a conditional urine reflex culturing, like previously I have discussed, no, if CU is showing less number of pus cells or WBC, they would not process it for the culture. Okay, by following this protocol, they have observed that there is a decrease in 39% of urine culture processing in the lab. Okay, the same way with the CLABSI. Okay, so if you follow the proper checklist, the fever checklist and blood culture ordering algorithm, they have observed approximately 46% decrease in blood culture reaching to the lab. In the same way, if you follow the proper blood culture algorithm and education to the healthcare staff as well as clinicians, provider feedback, if you have there is 18% decrease in samples reaching to the lab from the ICU and 30% samples decrease in reaching to from the floor. Okay, so always remember, in COTI, hospital onset Clostridium difficile and CLABSI, if you follow a structured pattern in the diagnostic stewardship algorithm, definitely there would be a decrease in the load to the lab, as well as it will improvise in reporting and appropriate care to the patient. So take home messages in the diagnostic stewardship: you should order a right test in the right sample type and the right time and the right treatment choice. Okay, so this is the basics of diagnostic stewardship, and thank you.
Good evening, everyone. Thank you, Dr. Rajkumar, for the wonderful lecture on diagnostic stewardship. And now let us move forward to therapeutic stewardship. Hi, I'm Dr. Komal Shah. I'm Associate Professor, Consultant Pulmonologist, and Infectious Disease Specialist from Nasik. Thank you, CCI, for giving me this opportunity. Ken Coleman once said that good questions inform, great questions transform. So, our today's session is going to be about questions and answers. So, questions to be answered are: what is antimicrobial stewardship? Why is it important? How can it be achieved with routine practice? What is the impact of antimicrobial stewardship? And we'll also discuss some cases for the practical demonstration. So basically, what is antimicrobial stewardship? Stewardship per se is the careful and responsible management of something entrusted to one's care. And antimicrobial stewardship are the coordinated interventions designed to improve and measure the appropriate use of antimicrobials by promoting the selection of optimal antibiotic, dose, duration, and route of administration. Why is it important? This article, which was published in Lancet in 2022, suggested that in 2019, in antimicrobial resistant claimed around 1.2 million lives. If we progress with the same rate, in 2050, there'll be 10 million yearly deaths estimated. And if we look at the ICMR data, which was published in 2020, they collected culture reports from 30 different tertiary care centers, and around 65,000 cultures were checked. And the reports were shocking. The susceptibility of E. coli dropped from 86% to 64% from 2016 to 2021. Same way, Klebsiella pneumoniae susceptibility to imipenem dropped from 65 to 43%. And when we look at Acinetobacter baumannii, the carbapenem susceptibility is just 10%. So 87% Acinetobacter are now resistant to carbapenem. So this is very shocking and alarming. When we are talking about multi-drug resistant organisms, which are this one? They are E. coli, Staphylococcus, Klebsiella, Acinetobacter baumannii, Pseudomonas, and Enterococcus faecalis. They are called as escape organisms. And what is the mechanism of resistance in them? Those bacteria which are producing penicillinase will be resistant to all kind of penicillins. Those who are producing AMP-C will be resistant to penicillins plus third generation cephalosporins. Those which are producing ESBLs will be resistant to penicillins, third generation cephalosporins, and all cephalosporins. And carbapenem is producing organisms like KPC, NDM, OXA48, 2425. They will be resistant to all the beta-lactams, including penicillins, cephalosporins, and carbapenems. Also, when the antimicrobial resistance develops, there is risk of treatment failure, economical losses, resistant bacteria in normal flora, additional infection, and of course, adverse drug reaction. And that is the reason why we should take antimicrobial stewardship very, very seriously. And how can it be achieved? So we will be discussing in our panel that what are the strategies and what are the core components of antimicrobial stewardship. But if we want to simplify the thing, there are three steps. One is diagnostic stewardship, which you have already been discussed. Then there is therapeutic stewardship, which can be divided in two groups, that is empirical therapy and definitive therapy. So empirical therapy is something that we start before we know what infection is there. So first and foremost, first rule is only start empirical antibiotic therapy when you are suspecting an infection. So in 2021 update of surviving sepsis guidelines introduced possibility of withholding antibiotics if shock is absent and if you're not suspecting any infection. A quasi-experimental study of 201 patients demonstrated that an aggressive antibiotic therapy was associated with excess mortality and antibiotic use. So whenever you are not suspecting it to be infection, if there is some other cause, do not start with empirical antibiotic. There are some other studies which mention that in 1541 ICU patient and antimicrobial stewardship program that included antibiotics withholding in patients without evidence of infection resulted in absolute reduction of mortality by 6%. This is very important. But there are some situations where we must give empirical antibiotic therapy even without definitive proof of infection. And which are they? They are septic shock, meningitis, febrile neutropenia, HAP, CAP, and VAP, and necrotizing diseases. In this condition, even if there are no definitive proof of infection, we must start with empirical antibiotic therapy. Now, second question, how to choose empirical antibiotic therapy? So for this, there are three golden rules. First, suspect what bug you are dealing with and how do we know that which bug we are dealing with. We should always look at the site of the infection, whether it is upper respiratory tract, whether the site is lower respiratory tract, it is bloodstream, it is UTI, abdominal infection. Accordingly, we can suspect which bug could be sitting there. For example, if it is lower respiratory tract infection and the patient is coming from the community, it could be very likely streptococcal pneumonia or staph or some atypical organism. Second, always look at the local antibiogram, which bug is prevailing in that particular area. For example, if your patient is having hospital-acquired pneumonia, look at the antibiogram of that particular site. For example, ICU, whether your ICU is having Klebsiella, whether your ICU is having Pseudomonas. Accordingly, we can judge, we can just think of what bug it could be. Also look at the risk factors for Pseudomonas and MRSA in that particular patient. And very importantly, look at the pharmacokinetics and pharmacodynamics parameters of the patient. Whether whatever antibiotic you are selecting is penetrated well in that particular site, whether it is absorbed well, how is the kidney function, how is the liver function, and after discussing everything, you decide on the empirical antibiotic. So, also one very important question is whether empirical therapy should be a combination therapy or a monotherapy. Combination therapy in empirical treatment in ICU patient with infection and shock. So whenever you are suspecting that patient is having infection and patient is also in shock, it is better to give combination therapy. And which combination? Beta-lactam plus aminoglycoside is one of the best combination to start as empirical antibiotic. So this is a very important flow chart which mentions that if you are suspecting an infection and if the patient is in shock, start with combination empirical antibiotics. If the patient is suspected to have infection but not in shock, patient is quite stable, give monotherapy as empirical therapy as per whatever bug you are suspecting as per the local antibiogram and PKPD parameters. And third, if patient is stable also and you are not even suspecting any infection but some other condition, then withhold empirical antibiotic. Now we come to the definitive therapy. So this is also very important. So what is definitive therapy? Basically, after starting the empirical therapy, before that we have sent the cultures. So in 48 hours, when we are getting the culture reports, we escalate or de-escalate or switch from combination to monotherapy is the definitive therapy. So whether combination therapy or monotherapy as definitive or treatment. For example, if your culture grows Pseudomonas, now whether should be given two drugs, combination drugs, monotherapy. So combination therapy for empirical treatment is fine in infection plus shock, but for definitive therapy, monotherapy should be used as soon as possible from day 2 to 3 of antimicrobial treatment for most pathogens when culture reports and susceptibility is available. Combination therapy could be discussed in patients with CRE, that is carbapenemase resistant Enterobacteriaceae, and MDR Xenotropomonas maltophilia. Can we use carbapenem sparing agents in ESBL infection? This is a very important point because there was a Marino trial, a very landmark trial, where patients with gram-negative bacteremia resistant to third generation, ESBL is resistant to third generation cephalosporins. When they were treated with piperacillin tazobactam, one group was treated with piperacillin tazobactam and another group was treated with meropenems, and mortality was very high in group treated with piperacillin tazobactam. So the bottom line is, for ESBL infections outside the urinary tract, carbapenem sparing agents are not recommended. Are prolonged infusions and therapeutic drug monitoring useful tools for antibiotic stewardship? Definitely yes. Pharmacokinetics variability in ICU patient leads to significant risk of suboptimal antibiotic dosing. And survival is improved when combination continuous or prolonged beta-lactam infusions are used as compared to short-time infusions. Therapeutic drug monitoring should be reserved for prolonged therapy like endocarditis or when there is antibiotic risk of antibiotic toxicity. What should be the duration of therapy when we are giving definitive therapy? This is very important because most of our patients are receiving antibiotics for 10, 15, 14 days. So here they are mentioning that as per guidelines, the shortest possible duration when the patient clinically stabilizes, when the lab parameters are starting to reverse, that is the point when we should stop the antibiotics. Like acute exacerbation of COPD, around 5 days is also enough. Community acquired pneumonia, they're mentioning 3 to 5 days. And what we are giving 7, 10, 14 days. HEP and WEP patients 7 to 8 days. So shortest possible therapy, days of therapy when patient clinically stabilizes. Can we withhold antibiotics in ICU once started? So for example, if we have started empirical antibiotics, suspecting that there is infection, but if patient turned out to be viral infection like respiratory pharyngitis, rhinosinusitis, bronchitis, non-infections, cardiopulmonary disorders, misdiagnosed as pneumonia, patient with acute otitis media, skin and soft tissue infection, asymptomatic bacteriuria, all these patients, once you prove that this is viral pharyngitis, you should stop with the antibiotics. So in short, when we are dealing with the direct therapy, after therapy, after receiving the culture reports, after starting an empirical antibiotic, systematically reassess antibiotics after 48 hours, and de-escalation should be done as soon as possible. In absence of documentation after 48 hours, search for differential diagnosis and stop the therapy. Definitive therapy should be most often be monotherapy. A combination therapy can be discussed in case of difficult to treat infections. Use of prolonged beta-lactam infusions should be appreciated. Therapeutic drug monitoring is useful in selective cases. And short-term, 7-day therapy is effective in so many of infections. Procalcitonin can be used as a marker for further discontinuation of de-escalation. Now, what is the impact of antimicrobial stewardship program? So this was a study which we performed at our own institute, that is Dr. Vasantrao Pawar Medical College, Nasik, where we applied prospective audit and feedback as the strategy to apply antimicrobial stewardship for therapeutic stewardship. And what we observed that carbapenem days of treatment decreased from 217 from pre-ASMP phase to 162. That was quite significant drop in the number of days used for the carbapenem, days of therapy for the carbapenem. And with that, we could maintain the same amount of quality. That means there was no change in mortality and no change in length of stay. Means with the decrease in the total duration of antibiotics, we could sustain same amount of patient outcome. Now we look at one simple case, that is 70-year-old male who's a smoker, COPD. He is immunocompetent. He presents to you with cough, fever, breathlessness, and loss of appetite for 10 to 15 days. Obviously, we suspect here infection, so patient must be started on empirical antibiotic. This is his X-ray report. His gram stain is negative, and some fungal hyphae is seen. Patient, what antibiotic he is started? Just look at this. Empirically, patient was started on colistin, vancomycin, levoflox, and caspofungin. Not one, not two, three empirical antibiotics plus an antifungal. Patient was not responding, so BAL was done. BAL cultures were negative. Now what? So I'm asking you guys a question that whether the empirical treatment here is correct or not, and this is a failing exam. Patient is even worsening on this. Then what should be the definitive therapy in this patient that we will be discussing during our panel discussion. So to conclude, whenever we are deciding on what antibiotic we should give empirically and definitively, then we should look at these three steps. First, confirm the possibility of infection. Cultures always should be sent before antibiotics and use biomarkers and molecular tests to guide you whether it is infection or not. So once you first make your mind clear that whether it is infection or not. Step 2. If you think that it is infection and you want to start with empirical antibiotic, then decide on which site is the infection, what are the risk factors. Patient has risk factors for Pseudomonas, MRSA, or gram-negative multi-drug resistant organism. Then look at the antibiogram of that particular area and also look at the pharmacokinetics and dynamics of the particular patient. And on all these four factors, decide on what empirical antibiotic you want to give. And if the patient is having septic shock with infection, it is better to give combination therapy. And once, after 2 to 3 days of starting the treatment, you have the culture reports, you have the susceptibility pattern, and you have the clinical response of the patient, you start de-escalating the therapy, you short down to monotherapy, narrow spectrum, discontinue if you feel that this is not an infection. The duration should be as short as 5 to 7 days. Prolonged infusions and therapeutic drug monitoring always help. I would like to end my lecture by saying that the person who takes medicine recovers twice, must recover twice, once from the disease and once from the medicine. Thank you.
Thank you, Dr. Rajkumar and Dr. Komal, for your wonderful talk. I think you both have covered most of the aspects of antimicrobial stewardship and the current challenges that we are facing and what is an ideal way to go forward. So to start with our panel discussion, I first start with Dr. Nitin. What do you think, sir? What do you think is a magnitude of antimicrobial resistance problem in India? What is your comments on it?
I mean, to put it very simply, antimicrobial resistance, A, is on the rise all the time. It has been worsening. I think we had a hiatus when there were almost no antibiotics used during the COVID time, and we had 1.5 to wonderful years of almost no antibiotic usage or very, very minimal antibiotic usage. But I think we have gone back to our old traits of, using, abusing, and overusing antibiotics. So I think we are back to, we were caught up with the times, and we are back to where we started, where we were. So at
So
this
is
point
this in the
time,
alarming state?
it's definitely in an alarming state. And the worst is anybody who has whatever degree who can prescribe an antibiotic is prescribing an antibiotic, right, left, and center. And I once it's crazy to say this today in 2024, but I see people writing meropenem 250 milligrams twice daily for 3 days and something like that. I mean, it's craziest kind of thing, and it still happens in our country at this point in time in our part of the world. In my part of the world, Komal is from Nasik. I am somewhere in the middle, and I see that happen in the areas in between. So it's not all that good. I mean, it's great to talk stewardship and big words, big terminologies, but what is happening in real life is much, much worse than what we can even imagine.
I think Dr. Komal has also mentioned in our statistics also and the ICMR data also how it is being alarming and it will going to increase in the near time and it will cause a huge toll of mortality also. So, Dr. Rajkumar, what do you think are the factors responsible or which can contribute to antimicrobial resistance in general?
Actually, the antimicrobial resistance, it starts from the community itself. Okay, the over-the-counter like availability of antibiotics. Okay, due to even the non-infective or viral etiology, the usage is more in India. The availability is very easy. Anyone can go to the pharmacist and take an antibiotic. So, some kind of drug control regulation might help in decreasing the antimicrobial resistance. But this is one of the factor contributing to the antimicrobial resistance. Coming to the hospital per se setting, over prescribing the antibiotics by some of the clinicians and inappropriate indications of prescribing an antibiotic, okay, and like incomplete duration, like either very less days of antibiotics or using antibiotics for more days than needed due to the fear that sepsis might reoccur, is also forcing the antimicrobial resistance. And the third part would be, see, not many hospitals or institutions will have a proper antimicrobial stewardship program. If the hospital has a proper antimicrobial stewardship program, probably the antimicrobial resistance might come down. And the other part could be the overusage of antibiotics in the poultry industries and the fish industries, especially the prawn cultures, and also the overusage might also lead to the antibiotic resistance. This overall reasons are contributing to the increased antimicrobial resistance in this part of world.
Rightly said. So, inappropriate antibiotic, inappropriate duration. We have a differential part in our country as far as resources are concerned. So, not every hospitals have AMS programs running in it. So, these are the challenging stuff. Rightly said. So, Dr. Abhishek, AMS. So, if we see AMS, what it stands as an individual and a team level for a clinician?
That's a very valid question, Dr. Ankit. So at an individual level, we have antimicrobial stewardship, which covers both the diagnostic and the therapeutic aspects. So if I go with an example, if a patient comes to the emergency department, you should know that you have to send in a blood culture, you have to send in a paired blood culture, and you have to send in a blood culture before you initiate an empirical antibiotic. So these are certain aspects of the diagnostic antimicrobial stewardship. Then coming to the therapeutic part, like Dr. Rajkumar so eloquently said, that you have to make the correct diagnosis, you need to prescribe the correct antibiotic in the correct dose for the correct duration, and then you should know when to de-escalate. And coming at a team level, I think education of everyone around you, especially the physicians, forms a very important point. Forming an antimicrobial susceptibility pattern, especially of your local hospital, forms a very important point. Then ensuring that the reserve antibiotics are not abused empirically, ensuring that the antimicrobial stewardship program that is in place is being implemented. I think these are certain aspects that you have to look all over as a team.
Yes, rightly said. So I come back to Dr. Komal in that way. As rightly discussed, that AMS program, to implement an AMS program is a challenge for every hospital. But if we initiate this prospect, what would be the core elements for any hospital to develop its stewardship program?
Thank you, sir, for the question. And we have started MS program in our hospital in last 2 years only. So we know how to start it from the scratch. So the core elements are most elements which are used for most of the programs when we are running. But when we are talking about antimicrobial stewardship, first and foremost, we must have a leadership commitment. We must have financial, physical resources. Without that, like for our team, the Dean sir was the core person in our institute who wanted to start with the antimicrobial stewardship program. So if we don't have the leadership commitment, it cannot be run. Other important factors are accountability. Like we should have one physician or infectious disease specialist or somebody who knows about the antibiotics well, should be a responsible person for the who should have accountability towards the program. There should be a drug expertise, like a pharmacist who knows about the antibiotics, and the action plan. What are we going to do? Are we going to apply prospective audit and feedback? Are we going to have antibiotic turnaround time? What are the actions we are going to take? Then there should be proper tracking, proper reporting system, audit system, and education. So overall, it should be a good team which consists of a physician or infectious disease specialist, an intensivist, a microbiologist, a pharmacist. There should be infection control nurse, infection control team, a data analyst, and of course, we need resources to properly function all of them together.
So ideally, who should take the lead in this
Uh,
particular prospect? There are many people that are involved, but someone has to take the lead.
Right. So there are studies are about that also. So whenever a senior physician or infectious disease specialist or somebody who is from the clinical side takes the lead, it is working better. The reports of the study suggest that.
Yes, I agree with you. In some hospital, I have seen that the infectious disease officer is the microbiologist and they are taking the lead. But if we consider in toto, it would be nice to have a clinical side
Clinical side,
taking
yes,
the lead because he understands the totality of the situation.
correct. And it is
And
always better, and we can convince other physicians, other surgeons in a better way when you are a physician.
Hmm. Anyone from the house have opinion regarding that? Yes, Nitin sir.
Yeah, I think, it's easier said than done. That's number one. Secondly, I think you have to keep talking to the microbiologist all the time. And in COVID times or even before COVID times, we used to take joint rounds. So I think
Yes, it has.
me and my microbiologist would walk the wards, the ICUs particularly, and look for infections which are really dangerous, vis-a-vis look for antibiotic abuse, which is on the other end of the spectrum. And one way or the other, you come to a conclusion. If we jointly agree, and that then getting that consensus is not easy. It takes time, it takes a lot of patience, it takes a lot of legwork, and then somewhere down the line you get a proper so-called stewardship program. And my biggest worry is not the tertiary care hospitals. Tertiary care hospitals can do it. Komal can do it. I mean, I'm sure Jupally, Rajkumar can do it. I mean, so many of us, Abhishek can do it in his hospital. My biggest worry is what is happening in the primary and secondary care kind of
Yes.
scenarios where the antibiotic abuse is absolutely rampant. Absolutely rampant. The moment you write something like Zabizepta once in one patient, it gets multiplied into 1,000 because somebody thinks these people got success with this particular combination and I must use it. Meropenem is like, a gone kind of scenario. We are talking of extreme, we are talking of extreme situations, extremely resistant organisms, and where we realistically do not have very, very good answers. Even in those patients, those antibiotics are being abused. Why are they being abused? Because A, legislation does not prohibit from it. B, doctors do not stop, want to stop at a particular and say, okay, this is my limit and let somebody take over from me. That's the second part. And the third, patients want it. And
So
and patients want it means, I'm sorry, but I'll conclude with in the last 30 seconds saying that the concept of closed ICU versus open ICU kind
yes,
of
it is a debatable thought.
very, very debatable. And I'm not in favor of closed ICU kind of a system at this point in time. I am in favor of an open ICU system, but every one of us has to think, am I doing the right thing when I'm prescribing an antibiotic? Is this right? Is this enough? Is this too much? And if I ask all these questions to myself, most of the times we'll get it right.
So one message I could clearly get from Dr. Nitin sir is that at the tertiary level, possibly we could manage more efficiently with our effective antimicrobial stewardship program. The main challenge is the primary and the secondary level, that they needs to be more educated. They should need to use antibiotic very cautiously, precisely. That is very important. And the education has to be go to that level. That is very important.
Absolutely.
Sir, I have seen patients taking polymyxin at home. So they prescribe polymyxin, patients are taking it for days at home. How can this be justified? Like it has to be restricted at that level only.
Absolutely. I think, if you really look at many of the structures all across, say, the NHS, or if you look at the American system, a general practitioner is licensed to write antibiotics only up to a certain limit.
Yes,
And beyond it, there is no license.
So I think the easy availability of the antibiotic is a problem. Yes, sir.
It's easier said and done, and easier said than executed. But at the same time, I mean, I think we had a discussion with Komal in the last week on one of the Delhi conferences, and he said, I have an antibiotic resistant Pseudomonas which was on nebulized colistin for last 4 years. Once in a while, that would be an exception in this country, and the person would do brilliantly well if it is rightly chosen. But then who gets the right and who has the responsibility of executing it? So the rights are widely available. Responsibility is not taken or owned, and legislation doesn't exist.
Yes. So I think we can go on and on with this discussion. But Dr. Laxmi ma'am.
I'm sorry if I'm sounding a little negative.
That is important. That is important. The each and every part, the core and basic part need to be discussed. That what are the basic challenges that we are getting in prescribing the antibiotic. Laxmi ma'am, I am asking you I think the most toughest question in the beginning only. What is the golden rule of prescribing an antibiotic?
Yeah, first of all, good evening all, and Navaratri wishes, happy Navaratri wishes. And regarding the rule, like 10 commandments, our antimicrobial resistance group, technical group, national and international, they have put forth the golden rules in optimization of the antibiotic prescription. Actually, the 10 rules are, first of all, prevention is always better than cure. So first we have to enhance the prevention control, and then prescription of the antibiotic only when it is needed, and prescription at the right time, right dose, the right route, and selecting the right person. And we have to, that is the target treatment should be in the way of targeted treatment based on the investigations, because the 90% of the susceptibility will favor the success, and the 60% of the resistant test will give the good outcome. And we have to using that is shorter duration, so that de-escalation of the drugs at the correct time, and also the elimination of the infection by reducing the bacterial load by effectively when you're using the antibiotics, and supporting the surveillance. Everything we have to need a result. So the surveillance program, we have to support them in the case of the hospital-acquired infections, and the quality of the prescription, everything has to be assessed. And the staff education and training program, that is one of the rule. And also the supporting the existing expertise collaboration with the other disciplinaries is also important. So these 10 rules has to be followed for the effective antimicrobial stewardship.
Golden words by ma'am for the golden rule of prescribing the antibiotics. So Nitin sir, I'll just come back again to the Dr. Komal case that she discussed. That the male with some infection and the bowel was negative. So what would be your first choice of antibiotic in that particular case?
So once again,
Dr. Komal, yes.
Yeah, I don't remember it perfectly, but as I can see it, it was not.
So basically, sir, it was a case of community-acquired pneumonia. Patient came from the community with bilateral opacities, inhomogeneous opacities were there, query fungal, query bacterial. and patient was started outside for 3 antibiotics, including colistin and linezolid, and caspofungin was also started. So sir is asking what should
I
be the
know.
ideal empirical antibiotic here.
Yeah, if you really ask me, I mean, if I really am suspecting a true viral pneumonia, I wouldn't possibly give antibiotics at all. But if I
No,
mean,
sir, counts are high. So it was suspected to have
yeah, yeah.
bacterial first.
So exactly, and the next logical thought which Komal brings in is obviously correct, that there is a possibility of a coexistent bacterial infection, and how far and how wide can I go in the spectrum of using an antibiotic? So shall I start with cephalosporin sulbactam, or will I stretch it to for example, piperacillin and tazobactam, plus minus clarithromycin, because the data on community-acquired pneumonia tells me that clarithromycin or azithromycin reduces the overall mortality, plus minus an antiviral if I'm thinking H1N1. So maybe a fluvir or something like that. If you really see what is happening in my ICU, which has something like 100 beds, and most of them are something like either cephalosporin sulbactam or piperacillin tazobactam as a start on antibiotic. These are seriously sick patients. Almost all of them are requiring at least oxygen. Most of them are on non-invasive ventilation. And we still don't start with something like meropenem on day one. Absolutely not. So I think that's the kind of a, holding back kind of a mechanism, because I think we tend to throw kitchen sink at every patient, and
Yes.
literally kitchen sink, nothing else. And therefore, that the business of colistin comes in. Where do you think colistin figures out in the true algorithm of either community acquired or even hospital acquired infections in today's scenario? And it figures almost nowhere. I mean, very, very, very selective patients and very, very, very sorted out patients will require colistin. So I think that is one thing which has to be brought into everybody's mindset, that, well, I don't have to use my last resort antibiotics just because the infection seems severe. Community
Yes,
acquired infections will have a spectrum of
yes,
susceptibility. Hospital acquired infection will have a spectrum of susceptibility. If I am talking of in my ICU, drug resistant Klebsiella, drug resistant Pseudomonas are my main enemies, the commonest ones. And I would be covering them when I'm suspecting hospital-acquired infection. But it is a community-acquired infection. I don't have to use those antibiotics in the first kind of scenario. So I think that's
Wait,
that's that's how I'll place.
sir, excellently put. Because when we are suspecting community acquired pneumonia, it's mostly strep pneumonia or some susceptible organism only. So those patients,
Absolutely.
even if they are requiring NORAD support, even if they are in shock, they are responding well to cephalosporin sulbactam, and that could be the drug of choice. So we don't need to go to meropenem for such simple pneumonias just because the patient is in shock or requiring an IV. That is the bottom line.
Absolutely.
So
So I think the judicious use of antibiotic is very important in that sense. Ki you need to assess your patient. That is important, and you need to know the clinical parameters. But if there is hemodynamic instability, still you can use your empiric
yes,
antibiotics.
yes,
That is important.
definitely. Yes,
So everything needs not to jump to carbapenems and colistins.
definitely.
Exactly.
I think the House will agree to this point, or they have a different view on that. You would look into parameters in that
Yeah.
prospect.
Yeah,
No.
I think only the fact that somebody comes with a hypotension as a presenting feature is not going to decide my antibiotic. That's not the way of doing things. I would rather say, where did the infection come from?
Yes, exactly.
That's the bottom line. If it is a infection which is coming from hospital, patient has been repeatedly, somebody on a hemodialysis and gets a bad hap, I'm going to use my best weapons. That's a different story. Somebody coming from the community, even with a shock, I'm not going to use my last antibiotic as the first choice.
Yes.
Exactly.
So that is important. So we initiated the antibiotic. Now the important task come that how long we have to continue this antibiotic. So Dr. Komal has given an excellent preview on that. But still, I'll ask Dr. Rajkumar, what is the preferred duration of antibiotic?
Yeah, preferred
Any
duration.
step down criteria for you?
Yeah, preferred duration for me depends on the clinical condition of the patient first, and second, how optimal is my source control. So I would look into, rather than the numbers, I would look into these two things before I cut down the duration of antibiotics. But in general, if I would like to give it for about 5 to 7 days, but there are exceptions to it. Like if it is a joint infection, I would give it for more days, like 2 to 4 weeks at least. If it is a bacteremia and if the source is my line, central line, if I pulled it out, probably again 5 to 7 days. So roughly you can say that it would go with 7 days. And in special situation, like if I'm suspecting any endocarditis, I would go with a longer duration of therapy. Like if it is a MRSA bacteremia, I would give for about 2 weeks, and joint infection, I would extend it for more days. But primarily, you should focus on the clinical condition of the patient and your response to the treatment.
So anything would help besides your clinical assessment, like maybe cultures or biomarkers to step down antibiotic?
Yes, it would help out, like biomarkers, especially if the CRP, like recent trend, like CRP, it is not a costly investigations. It would like correlate with the clinical condition of the patient. If it is in a decreasing trend, definitely you are hitting the target. And if the patient is affordable and all, Procal also will help us in de-escalation of antibiotics. But routinely we are nowadays like CRP has like really helping us in de-escalating, and it is excellently correlating with the clinical condition of the patient.
That's very nicely explained. So one basic thought is that when we have to de-escalate the antibiotics. So Dr. Laxmi ma'am, there is another issue that comes in when we have to shift from an IV to oral antibiotic.
Yeah.
So any criteria for it?
Yeah. This is the first question comes from once the patient getting conscious or paused is critical. This thing, always this questions come from the attenders. When will have his oral feeds? So whenever the patient is having taking the oral feeds, then it can be the switch over from the parenteral to the oral antibiotics. It can be considered depending on with the caution that individual clinical setting and the availability of the antibiotics with the high bioavailability and the diffusion. So the patient, we have to look for the clinical symptoms progression, like the tools like temperature, respiratory rate, heart rate, then SpO2, X-rays, clinically progression, and the echo, and the blood counts, everything has to be improved. And then we'll have the oral, and the hospital must have the enough oral antibiotics. And
Yes.
it should, yeah. And we have to consider that it is very advantageous in the case of it is very cost effective, and it is a shorter hospital stay and reducing the risk of the other nosocomial infections. And there should be the close collaboration between the physician, microbiologist, and the pharmacist. Then only it can be decided. And the patient, and we have to look for the patient serious condition like meningitis, like that. It won't be the switchover therapy cannot be considered.
Yes. So both the aspects are very important. But Dr. Abhishek, we need to know when there is an IPD patient. IPD, we suspect that or we expect that there has to be some antibiotic. Are there any condition in which antibiotics can be avoided?
Sir, I think the framing of the question should be what are the conditions in which we can give an antibiotic? Because if I go on to list all the other conditions where antibiotics should and can be avoided, I think we'll have another webinar altogether. But having said that, sir, one thing that comes to my mind when a patient is admitted with a categorical viral infection that we know and we are sure of, even in this case of an IPD, when the patient is not on an oxygen or we are not suspecting a superadded bacterial infection, and straight away when antibiotics are given, like this is a cocktail regimen that if a patient comes in with a viral infection, you give an azithromycin, a Monter LC, a steam inhalation, and so on and so forth. And you tell the patient that, yes, we're covering each and every aspect that can be thought about, and you're going to be fine. So I think that needs to be restricted. And coming back to Dr. Komal's presentation, she had very elegantly listed certain conditions in which we have to start in with an empirical antibiotic therapy, even if we are not very sure of what the source of the infection is. For example, in case of a septic shock or in case of an meningitis, all the other conditions that she listed. So I think barring those conditions, unless and until we have a very, very strong clinical suspicion of a microbacterial infection involved, or we have evidence of a microbiological infection, we can withhold antibiotics.
I'll just to discuss with you that surgeons are very fond of antibiotics while doing a surgical procedure. Yes. Your thoughts and comments on it?
So we actually have a very good infectious disease department in our hospital, and they have formulated certain guidelines as to what empirical antibiotics can be used by a surgeon, when can surgeons use them, and what is the duration if they need to for those antibiotics. It's a completely different ball game together that surgeons mostly ignore those guidelines and guidelines, but yeah, they are in place. And I think each and every institute should have these guidelines as to when should empirical antibiotics be used in a surgical patient.
And also, it's a very nicely put by Dr. Abhishek. And I would like to add to that even if we have started on empirical antibiotic, we can stop it the time, the moment we feel that we get to know that this is not a bacterial infection. So even if we have started, just stop it when you get the answer.
Yeah.
Yes, sir, please.
Yeah. Simple story. I mean, today we had a person with a recurrent spontaneous pneumothorax, and I am a half surgeon, so I mean I do thoracoscopy. So the question asked yesterday by my resident is, sir, isko antibiotic kya dena hai? Because most of my patients are medical and they require antibiotics one way or the other. So I said, no, ek supasip dena hai, 1.5 grams before the procedure, and that's it. And after that, we wouldn't be using anything else because we are doing an invasive procedure and end of the story. And after that, if I require, I'll tell you tomorrow. So I said, can we not sort of preempt the whole issue and say, can we not continue SuperSafe forever? I said, no, that's not going to be the story. So I think one way or the other, the stewardship is not based on an institute. It's not based on guidelines. It's not legitimate in our country at this point in time. It's in the sense of, legislature does not lay down saying that this is right, this is correct, this is perfect, nothing like that. More often than not, people will be accused of not writing an antibiotic in appropriate time rather than the other way around. Overuse of antibiotic will be appreciated or rather ignored. So one way or the other, I think stewardship has to start from within rather than from above. And well, I mean, Abhishek has something to add. So
just to retaliate on that, sir, we have attendants who come and ask us for patients who are admitted in an ICU. Why are you giving our patients ceftriaxone sulbactam, and why aren't you not putting meropenem upfront? They ask us.
No, exactly. Absolutely. And
for that instance, I'll say that my residents, in spite of being in pulmonology department, they are giving better antibiotics than medicine department because they are trained like that. So whenever a patient is admitted in medicine department, they start with Mero, and our residents start with Augmentin. That's the difference. What we are seeing these days.
Absolutely. I think it's all about awareness, recognition, and then action. So I think it's a process. It's not going to happen overnight, but at the same time, awareness is the first story, and we still are in the pre-awareness zone rather than awareness zone. Most of us.
Dr. Komal, actually, you said that you are starting the department from the scratch, like antimicrobial stewardship.
Right.
Like, what it has been your experience so far with the surgical? Because it is very difficult.
Yes, it's
to
very
convince.
challenging also to
Yeah,
convince the
with
surgeon.
one dose, no one would listen. Actually, we have to accept it. Even in the tertiary care hospitals with a proper AMSP program, also, it is very difficult to convince a surgeon with a single dose of antibiotic.
Yes, very valid point put up by Dr.
Yes.
Rajkumar.
Sir, it is very difficult. I agree to that. So I'll start like we started the program first in medical ICU and we saw the good results, which I have already explained. Now, our dean is a surgeon and he was very much impressed by the stewardship which happened in the medical ICU. So he wanted to put the same thing in surgical ICU. That was step 2. And because he is the dean and he has convinced all the surgeons, so my half work was done there only. Still, as you are rightly saying that they don't agree to one dose, so we have to negotiate with them. We cannot absolutely tell them that no, only one dose will be fine and this that. But still, in my hospital, they are very much cooperating now since they have seen the results.
Okay. Very nice discussion on that. So moving forward, Dr. Komal, what are the effective antimicrobial strategies that you can think of could be implemented at an individual or the hospital level?
Right. So there are multiple strategies, but I'll like to discuss 2 basic strategies. One is pre-authorization and the second is prospective audit and feedback. Now, in pre-authorization, what we do is we restrict the use of certain antibiotics which are very precious or crucial antibiotics, and the prescriber has to give in return that why the prescriber wants to give the antibiotic to certain patients. But there are some lacuna in this, because see, if the patient comes in the middle of the night, if the intensivist wants to give certain antibiotic, how are we going to justify where to take the permission, where to fill the form of pre-authorization, things like that. Plus, sometimes the people feel offended. Now, what we are applying in our institute is prospective audit and feedback. Prospective audit and feedback mean we have the antimicrobial stewardship team which takes the round of the patient. We have decided the days and accordingly we audit or we review the prescriptions. And as per the hospital antimicrobial policy, we suggest them that, sir, you could use this particular antibiotic in place of this antibiotic in return. And we also give our justifications and explanations. And accordingly, the final authority is on the prescribing physician or surgeon, that whether they want to follow our instructions or not. But this strategy works very well. In overall world, we have seen the reports, the case reports also, that prospective audit and feedback works better than pre-authorization. And we are continuing with pre-authorization in our setup. Dr. Rajkumar, what strategy you are?
Actually, what we do is initially we had this discussion. So for the initial dose, especially in the night shift as an intensivist, the intensivist has the choice to give the antibiotic of his choice. Later on in the morning, the second dose will not be indented from the pharmacist. You have to fill the form, you have to talk to the concerned team, and then the second dose of antibiotic, that is the judicious use of antibiotics, will be dispensed from the pharmacist.
Similar strategies
so you are practicing pre-authorization in your institute?
Yes, pre-authorization definitely during the daytime. In the night time, the intensivist, the drug will be dispensed, but the next day you have to give an explanation, otherwise it will not be dispensed.
Okay.
We are also practicing a similar thing in our setup. Yes.
And which all antibiotics you are pre-authorizing, sir, if may I ask? Dr. Raj.
Yeah, we have a list of pre-authorization, even like colistin, polymyxin B, ceftazidime avibactam, teicoplanin, and carbapenem. So we have to give an explanation form.
So even for carbapenem, you have said.
Yeah. Even for carbapenem, we have to write a pre-authorization form.
That's a very good thing. Then.
We also.
I think it's a must. I mean, very frankly, carbapenems should not be the first choice at this point in time.
But to make it a pre-authorized thing, sir, it is very difficult. Carbapenems, it is difficult, I feel.
It should not become an automatic choice in everybody. I mean, just because the patient.
No, what I felt was even for the carbapenem, in the earlier hospital where I worked, there was no pre-authorization. But now, where in the hospital where I work, the carbapenem pre-authorization is a must. So what I observed is that the tendency of the clinician to write carbapenem like immediately will come down. He will think twice before putting carbapenem in the drug chart, because he has to fill the justification form.
And
Correct,
Komal,
correct.
in your data, you showed just 5 or 7% reduction in the carbapenem usage upfront. I think it's a very, very important thing for a country like India, 140 billion, crore people. It makes a big, huge difference of carbapenem abuse. It reduces it by 5,
Yes.
7%. Great deal. I would say phenomenal.
Yes. So, any views, Dr. Abhishek? Thus, I think similar practices at your place also.
We do have a pre-authorization where the clinical pharmacist actually comes and asks us. Sometimes we feel very in a busy schedule
Often,
and he's asking us to fill that form, but
Irritated.
it's really very
Irritated. Yeah.
important. But the pharmacist is after our life. कि नहीं sir, अगर आपने लिखी है तो आपको भरना ही है.
Yes.
So, yeah, but we
Um,
do it for
Very-
meropenems because I don't know how Dr. Rajkumar is doing it. It's a hideous task. I guess it's a 1,000 bedded hospital that I work in, and at any given point in time, I'm sure more than 100 patients are on carbapenem. So to pre-authorize carbapenem for this magnitude, it's a task. And I hats off if you're doing it at your institute.
Yes. So I totally agree with Dr. Nitin sir regarding this. This is a challenge. And he has been constantly talking about the challenges at the primary and the secondary level. But ultimately, sir, what should be the goal of the antimicrobial stewardship program? And what is the evidence of success for it?
Very, very difficult to define because see, in it's like what way are you looking at? Look at the COVID pandemic scenario. COVID pandemic scenario, almost nobody required antibiotics. People were sitting at home. There was no secondary, tertiary. We did not deal with a lot of Acinetobacter baumannii. In fact, the worst I dealt with was steroid-related mucormycosis, if at all. So the worst infection I dealt with was that. And all said and done, we did not lose people because of bacteriomial sepsis as a primary cause of death during COVID pandemic. So it depends on situation to situation, scenario to scenario, and it will keep varying from time to time. But at the same time, we must be alert to the idea that look, at all times, if I'm just going to use the same bloody, and I'm sorry to use the word swear word, but same damn thing which I would want to do right, left and center, and नींद में से उठ के हाँ सर इसको मेरोपेनम जो भी whatever मेरे मन में आया वो चालू कर दो. That's not going to be the appropriate way of ahead. So I think that I keep on harping on this myself and to myself also that it is not the stewardship which has been ठीक है प्री ऑथराइजेशन है मुझे जस्टिफाई करना है, but at the same time my heart or rather my brain should be convinced that this is the appropriate antibiotic for my appropriate patient and appropriate time and appropriate dosing. All those prerequisites which were defined by Rajkumar in the first talk, I think they are very, 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 very important. Unless until I'm convinced on that, that is the story. That is the beginning of the story. Am I writing the right choice? Am I making the right choice, right dose, right time, the right patient? All those prerequisites have to be fulfilled before I move on. And if I'm not convinced on any of these parameters, I can hold back by one day. I'm sure the other way around, there are arguments in favor of it, that a delayed antibiotic also will kill people.
Yes.
Agreed. At the same time, in the same breath, we have to say that if the genuine sepsis and I miss it, a genuine infection need and I miss it, I'm going to lose lives. So the correct balance has to be strict. And that only a clinician can do it. The others will help us in doing it.
Yes.
A microbiologist is my great ally. Absolutely no doubt about that. A stewardship program is my great ally because it will put some kind of checks and balances on what I'm doing. But at the same time, I have the responsibility of saving a life. And given that situation, I have to, in a given situation, as beautifully said by Abhishek, that I think, writing the first dose is the intensivist prerogative. The writing of the pre-authorization of the second dose, very important. That
Yes.
means we have the checks and balances in place.
Yes, definitely. So, Dr. Rajkumar, that there has always been a debate between a bolus dose and by infusion. The PKPD plays a very important role. So, how to achieve that adequate serum concentrations? What is your thoughts on that, bolus versus infusion?
Yeah. So the basic idea where this bolus versus continuous was based on the pharmacokinetic PKPD basis only. So initially, the basic is to maintain the drug concentration above the MIC. So that's what we wanted, to kill the bacteria in a better way. Like initially when it came in, like the carbapenem infusion, like 2 to 3 hours, meropenem for 3 hours, and imipenem for 2 hours. Definitely what we observed was the number of like adverse effects related to the bolus dose. When we give the meropenem in 100 ml NS, load it in 100 ml NS and give it in 5 to 10 minutes, the related adverse effect related to the infusion, we saw it more. What we practice in our hospital is, like, if we are giving a carbapenem, we give it in an infusion form, like in a syringe pump, load it in a syringe pump in 50 ml, and we would give it in an infusion, like meropenem for 3 hours and imipenem for 2 hours. There is some studies have been done regarding this continuous versus bolus dosing also. They didn't show any mortality benefit, but some of the studies have proven that there is decreased fever duration when compared to the bolus doses, and very few adverse effects related to the bolus dose when compared to the bolus dose has more adverse effects than the continuous infusion. So, what do you practice, sir?
In certain group of antibiotics, definitely we go by infusion, like meropenem, sometimes ceftazidime, avibactam, azotrenum. We give by infusion.
So I usually give by infusion 3 to 4 hours. There are even data for continuous infusion for meropenem, but we are not practicing that. But at least for 3 to 4 hours.
Yeah, there are some papers for continuous infusion of 24 hours. I don't know how do they.
Very difficult to achieve.
But 3 hours
very difficult to have. Yeah. So that's why we are giving it like almost 10 hours to hui jata hai, because 3 hours, 3 times a day we are giving. So that should be more than enough, I guess.
Okay. So a very important question when we see the culture reports, maybe it could be blood, urine, sputum. An important figure is MIC. So how to interpret it, Dr. Komal?
So MIC is basically minimum inhibitory concentration. That is the minimum amount of a particular antibiotic required to inhibit complete growth of that particular organism. That is MIC. Now, there are two methods of doing it. One is dilution and one is the gradient method. We don't need to go in detail, but we should know that these are the methods by which it is done. Now, very importantly, how to interpret it. So, there are MIC is basically determined by comparing it with the clinical breakpoint, that is called as CBD, clinical breakpoint. CPT is the clinical breakpoint is given by UCAS system, that is European, and also by the American CLSI system. So whenever we are getting a culture report, we get a report like MIC for this particular organism of MIC for meropenem is less than 2, for example, and for piperacillin tazobactam it is less than 8. So what we usually think that meropenem is 2, that's why it is less than 8, that's why it is more effective, or there are less chances of meropenem to get resistance in future. But it is not like that. We have to compare it with the clinical breakpoint of that particular drug for the particular bacteria. Like for example, for the same organism, MIC by UCAS system will be for that clinical breakpoint for that system, that meropenem will be 2. So 2 divided by 2, the MIC will be 1 here. And for piperacillin tazobactam, if the given MIC is 8, but clinical breakpoint is 16, so it will be 8 by 16, then it is less than that 1 what we got for meropenem. So that's why here piperacillin tazobactam is a better antibiotic choice than meropenem. So it should be interpreted with the help of clinical breakpoint. That is the final thing. And for that, in some culture reports they are giving, but in most culture reports they are not giving clinical breakpoints. Then we have to actually open the site of UCAS and then we have to see that what is the clinical breakpoint. But generally we know for some of the antibiotics.
I think that is why the rounds with microbiologists is important.
Yes.
Because we can interpret the culture report more efficiently.
I would recommend, for everybody who's working in ICUs, at least 1 month of a year, you should take a round with the microbiologist. It's worth it. And I'm sure Rajkumar will be thrilled to do that with, because,
Yes.
they are, sitting in the laboratory and reporting and seeing a patient are two different things.
So both will get benefited, na?
Both get benefited. I get much enriched by their knowledge, and they get much better sense of belonging to the system rather than just reporting it from or some kind of a jury kind of a system where say हाँ ठीक है ये लिखना है तो लिख दो नहीं लिखना है तो लिख दो आप लोग देख लो. No, that kind of a story. So they don't belong. And I think it's a question of belonging.
I think in a tertiary AMS,
I would take it for every tertiary care center. A microbiologist taking rounds of the intensive care unit or whatever that scenario is, it's very, very.
Yes. So tertiary AMS, I think that should be an important point to practice.
Yeah.
Especially, sir, whenever we are dealing with MDROs, multi-drug resistant organisms, we should definitely discuss with the microbiologist.
Is your lab reporting the MICs, Dr. Abhishek?
Yes.
Okay. Is it given in the printed report, the MICs, or you need to call the microbiologist?
So MICs are reported, but the clinical breakpoints are not. So
breakpoints are not reported.
Not reported, but MICs are routinely reported regularly in the printed form.
So in our institute, it's not mentioned also.
Not mentioned.
So we have to, we have to call.
I have to call the microbiologist. They just mentioned as sensitive or resistant. We have to call and even if it is sensitive, for some bugs, we will call the microbiologist and know the MIC for the best.
Yes. Okay. So Dr. Abhishek, carbapenem resistant Enterobacteriaceae, a challenge. Our existing armamentarium of antibiotics are reducing. So we have some new antibiotic combinations that are there. In that, one of those is the synergistic effect of ceftazidime avibactam with azotenam. So how you interpret the usage of this combination? What is synergy test? How the combination needs to be given? And what are the advantage that you see in your clinical practice?
Sir, for CREs, that is carbapenem resistance Enterobacteriaceae, especially which have the NDM type, as Dr. Komal had said, a carbapenem will not work. So we have this combination where we use ceftazidime, avibactam, and aztreonam together. So before we use it, what we have to do is, like, for example, if we obtain an E. coli, and the E. coli is resistant to ceftazidime, avibactam, and it's also resistant to aztreonam. So we have to test whether the isolate is resistant or sensitive to a combination of ceftazidime, avibactam, and aztreonam. And this is what forms the basis of a synergy test. So in our practice, what we have seen in our local antimicrogram, that for a E. coli and a Pseudomonas, the isolate, what we do is we expect it to be resistant, even in case of a synergy, unless and until proven by a synergy. So if we isolate an E. coli or a Pseudomonas, we'll not upfront start with a ceftazidime, avibactam, aztreonam. But in case we isolate a Klebsiella pneumonia, so what we have seen is that 95% of the cases, the Klebsiella pneumonia will be a synergy positive. So we can initiate them on a ceftazidime, avibactam, aztreonam upfront and not wait for the synergy test. So this is how we do it. For KP, we initiate it and then de-escalate in case a synergy is negative. But for an E. coli or a Pseudomonas, we wait for a synergy before we initiate it. And having said that, one question that you asked was, how do we do it? So in our center, how we do it is we take 2 infusion pumps and we take a 3-way in the same cannula, and we put one end of ceftazidime, avibactam at one end of the 3-way and the aztreonam at the other end of the three-way, and we infuse it together for over 3 hours. I don't know how Dr. Komal and Dr. Rajkumar are doing it at their centers, but this is how we do it. And Nitin sir can also chip in. This is how we are doing it.
We do the same at our center also.
Exactly.
Dr. Komal and Dr. Rajkumar, sir.
Yeah, actually, sometimes if the patient is on vasopressors and he's requiring in a triple lumen central line, actually sometimes if the access is not, if he's not on too much of vasopressors, we will be using the 2 separate lines for ceftazidime avibactam and aztreonam rather than this 3-way. If the line there is a scarcity, definitely as we would be using the 3-way.
But it should be at the same time. That is the point. Whether we are using two lines, 3 lines, whatever.
Should be the same time.
Same time.
And always.
And it should be the infusion over 3 hours.
Yes. So, Dr. Laxmi ma'am, what are the challenges particular clinician face while practicing AMS?
Yeah, the challenges mainly it is varies with the different clinical setting. That is tertiary. It is morely in the secondary and the primary care settings, where there is a lack of awareness, the acceptance by the physicians. Because even when the susceptibility testing is available, they are not using, and unnecessary prescription for the broad spectrum antibiotics wherein there is no evidence of the infection, and there is a lack. Mainly, the physician perception is on the patient thing with the antibiotic use, and lack of the knowledge regarding the antibiotic prescription. With the already we told that 10 rules has to be followed, but that does not. There is a lack in that, and there is a lack of support. There is an inefficient workforce and monetary losses, and that is monetary requirement is more, and there is a suboptimal cooperation between the interdepartments, and there is a diagnostic barrier, that is availability of the new technology, and there is a difficulty in the documentation process, and there is a disinterest among them, and the availability of the antibiotics according to the promotion by the pharma companies that will be available. Availability is based on that, and the emergency of the specific diseases that makes them to prescribe, that is antibiotic prescription, is not optimized in that. So these are the challenges mainly faced by the clinicians.
Definitely agree with
AMS. Yeah.
Definitely. So, Dr. Rajkumar, there is one important consideration in the diagnostics. Now, there is battery of tests that are coming in, some PCR-based tests, biofire, some markers like galactominin. Are they useful in the real practice? Because they are taking a cost, and the cost is increasing. Are they really useful?
Yes, I say it is useful, especially like in a critical care setting. If you consider like 2 scenarios, one patient coming from a community with a suspecting viral pneumonia, definitely the rapid diagnostic test helps in a 2 ways. One is the identification of viral pathogen, so that I can give an appropriate treatment to that patient by decreasing the antimicrobials. Second, in infection control policies also, like I can isolate the patient. Okay, so what kind of droplet precautions or aerosols precautions should I take? So it helps in 2 ways, the rapid test. The second thing which we are more considerate about is the ventilator associated pneumonias, where I can send the sample and know the exact like bacteria which is causing this and what is the resistance genes in that particular bacteria, so that I can initiate an appropriate antibiotic, whether it is a oxa producer, whether it is an NDM, okay, or whether we expect co-producers also. So it is very easy for us as an intensivist to titrate the antibiotics by this rapid diagnostic tests.
Biomarkers?
Biomarkers, yes, sir, like galactomannan, especially if the radiological investigation, if we are suspecting any invasive aspergillosis, it is really helpful, but you should be more cautious interpreting the serum galactomannan also, especially if you should have an idea about the false positive tests also.
If I have to do it and if I have the access, I'll do a bar galactomannan or something which is going into the lower respiratory tract and taking a sample.
Yes.
So if I have that high, I would definitely go in favor of it.
Anyone has different opinion using these rapid diagnostic test?
I just want to ask Dr. Rajkumar one question. As in our center, we are only sending a ball for a biofire. We are not subjecting a ET aspirate or a sputum for a biofire. Are you doing the same?
Actually, we had this practical issue. See, like you have a long-standing case on tracheostomy. Okay, so the patient might spike fever. You don't know whether it is per se due to like a lung infection or due to any other cause. So there comes your clinical acumen of deciding on to whether there was a recent increase in oxygenation, whether your lung plateau pressures are changing. So it depends on it, because definitely a sample, a tracheal sample, if you send, there will be a colonizer and it can mislead you. Okay, so that sort of like clinical discussion should happen with your colleagues, and then interpret the like lab results in an appropriate way. Whenever there is only change in this dynamics, try to interpret it. If possible, do a ball.
Yes.
Yeah,
Yes,
sir,
Dr. Nitin, sir.
Sorry, can I add one? I
Yes,
think
please,
very
please.
well said, Rajkumar. I think add to that, the freshly intubated patient is the best sample taking opportunity for taking a lower respiratory tract sample. Somebody who requires an intubation is not a stable patient.
No.
He doesn't require it for, say, a cardiac emergency or a cardiac catastrophe or a cardiac arrest, and he's requiring it because of the pneumonia worsening. I think he's a beautiful candidate to take a lower respiratory tract sample from even the tracheal aspirates. It will be good enough most of the times.
Yes,
and you
sir.
can go as deep as you can, and you don't have to do a bronchoscopy. So it is almost equivalent to a BAL in interpretation. If you have your heart in the right place, if your brain in the right place, mostly will make sense. Well, I mean, once in a while you can go wrong. Well, but then that will be a small minority of the situations. BAL absolute indication would be, if I'm really thinking of a fungal and I'm not really too sure, that kind of a scenario, BAL galactomannan plays a bigger role in my mind. Otherwise, the moment I intubate, and I'm suspecting a worsening scenario, I would do a pneumonia biofire panel. And for a rapid, quick decision-making test, beautifully executed. And of course, the cultures will follow. I'm not saying no to cultures, absolutely not. So the cultures will come back in 3 days.
But at the same time, sir, we have to also look at where we are sending the biofire, because nowadays so many labs are doing this test.
No.
They are not even
We have it
standardized.
in-house. We have biofire in-house.
Oh, I know, sir. So
We also have it
many
in this.
you have
Yes.
in-house,
Yeah.
Yes,
but
definitely.
it is standardized with the normal.
Yeah.
This
So
thing.
they talk to each other all the time. They can't fight amongst themselves. There's no question.
So, Dr. Komal, there are MDR bugs everywhere. MDR, Acinetobacter, Klebsiella, E. coli. So, how we can reduce the burden of this MDR besides our antibiotic therapy?
Correct. So we have been discussing this so far only. It's been starting. We are discussing this only, that it should be a multidisciplinary approach. The infection control measures and infection control team should be in action. Hand hygiene, isolating the resistant organism patients, and environmental things. These are very important. Plus, prevention is better than cure. This antimicrobial stewardship program ultimately will cover everything to reduce the burden of MDR organisms. That's what I think.
Yes. So definitely agree with you. Dr. Laxmi ma'am, antimicrobial stewardship in IPD we have discussed. So it can be applied to OPD patients also?
Yeah, definitely. But OPDs are the places where there is a lot of overcrowding and transmission of infections is more. And regarding the recent report says that more than 60% of the expenditure is antibiotic expenditure is coming from the OPD departments only. And the core elements, as Dr. Komal said, based on the four elements are there. That is the commitment to optimize the antibiotic use prescription with the pay for the only looking at the patient safetyness, and there is a action for the policy and the practice to improve the antibiotic prescription, and identify the opportunity with the access to the expertise. So then and then we get the expert opinion from them, and tracking and the reporting. That is, whenever the local pattern of the antibiotic resistance that has to be known, and minimize the duplication of the results, and testing, that is, and facilitate the proper patient transition. Suppose if you are not able to do, then patient has to be transferred without unnecessary test, and cooperate on the quality enhancement and the information sharing. And the last thing is the education on the participants. That is best practice education on the best practice, and the clinical practical guidelines has to be followed. So the state has to take some crucial role in promoting the AMS program in the OPD as well as in the IPD also. And based on the diagnostic, they have to teach on the important diagnostic criteria and treatment recommendations, and using the e-system and video calls so that the unnecessary patient visit can be minimized. So in my experience with the TB department, this and all we have done during our field visits, where we have reduced the airborne infection transmission by the environmental spacing, everything, patient waiting area, and training because primary care setting doctors are the untrained actually. So we have to train them a lot to bringing in success in the antibiotic writing, and that is referring of the patient to the well-equipped center when they are suspecting the that is not the usual thing. For the higher thing, we have to refer them to the higher centers.
Yes.
So that and the availability of the rapid testing equipments where and all it is available, that they have to teach them so that the proper referral at the patient at the right time, so that the patient will get the right treatment and the safetiness.
Agree, ma'am. Definitely agree. So, Nitin sir, are there any measures for quality improvement in AMS program?
I think, we were talking of too many ideal things, and this is one more.
We are taking both the prospect. We are discussing the primary and secondary level also, and we are discussing the tertiary level also, because some way we have to implement the best practices also.
Yeah. So I think, the issue of, frequent auditing.
Yes.
Going on to explain an unexpected death and having a death audit on routine basis is going to be one of the best quality things which we can incorporate. Having a local antimicrobiome is invaluable, no question about that. I think knowing what are your drug resistant bugs and what can be my best empirical choice is based on what is the local antibiogram. And without that we can't move. But you can't qualitatively say, okay, when these are the only things by which I will go by it. And then the clinician finally has to, one way or the other, contribute maximally. Microbiologist is my second best ally, and there are a number of them in addition. So I think one way or the other, the ID experts walk in whenever there is a need for them to walk in. I would be happy to take a consult when it makes sense, because recently we had a so-called bacterial meningitis where the ID felt the story doesn't really fit into the bacterial, and he said maybe it is listeria, and the MP added an MP-like drug giving phenomenal results, and we are discharging that patient tomorrow. So I think one way or the other, incorporating your ID consultants into the scenario, it's not, we are not gods. Nobody's.
Yes.
Physicians are not gods. IDs are not gods. Pulmonologists are not gods. They all add together.
Yes.
And microbiologists are semi-gods to us. So because they are almost giving us the,
Yes. A teamwork is
So the whole team has to come together.
Yes.
I wouldn't dare say that only one cog of the wheel is the whole wheel. Not at all. We all have to fit together and make sense, and minimize abuse, maximize precision use. I think that's there.
Yes. In the last few years, the few good things that has happened, that we are coming up with some consensus guidelines in various fields, maybe pulmonology also. Critical care ICCM has also done their task to come up with some consensus guidelines for antimicrobial uses in Indian setup. So, Dr. Abhishek, your thoughts on it?
Sir, I think it's a great effort. To be very honest, I am pretty certain that most of the physicians are not even aware of the existence of such a guideline. But the fact that the guidelines are being put into place, people are talking about it, antimicrobial stewardship programs are being set up in certain hospitals, speaks volumes about where we were 5 years down the line and where we are now. Having said that, ICMR has come up with a guideline for the judicious use of antimicrobials in the Indian subcontinent. I think that the guidelines are very beautifully written. They have told us when to use which antibiotic in which setting, when the site of the infection is what, in what dose, for what duration, when we have to de-escalate them to which oral antibiotics. And I think every one of us who is listening to this webinar today needs to go down and go through these guidelines at least once, so that you get a clear idea as to what a judicious antimicrobial stewardship program is all about.
Yes, I totally agree with you, and everyone should read those guidelines and try to practice according to that also. That is important. I know there are certain practical challenges they are there, but still we can follow that. So I'll quickly take some audience question. Dr. Tridip Chatterjee from Maharashtra is saying that in a patient or imipenem like meropenem IV for say 5 to 7 days. Just a moment. Sorry, one question is that a patient on IV meropenem and Targocid in ICU critical patient before any cultures are available, is this the empiric therapy of choice, or they become negative, or we should add an anaerobic coverage to it? Anyone from the house?
Whenever we are giving meropenem or piperacillin tazobactam, it has a very good anaerobic coverage as well. So we don't need to use metro. This is a very important point, that we do not need to use any other anaerobic cover when we are giving piperacillin tazobactam or meropenem. However, in third generation cephalosporin, we need to add if we are suspecting aspiration or something, like whenever you want to cover anaerobics. But otherwise, when you are giving meropenem, no need.
Okay. Again, there is one question from Dr. Sidip, is that what is the recommendation for blood cultures? 2 sequential ones, time duration, any role of collecting during peak fever response? Anyone?
Ideally, it is supposed to be before the next fever, and that's really difficult to achieve. But at the beginning of the new fever, maybe the best case scenario in clinical.
And ideal time, if the patient presents in the emergency, before you administer.
Before the antibiotic.
Before the antibiotic. That is obvious.
And 2 sets of blood culture, minimum 10 to 20 ml of blood, as much as you can. So more the amount of blood, more the chances of bacteria growing there. So sometimes we have seen that nurses send only 5 ml, 7 ml, 10 ml. So usme grow nahi hoga. So we have to give a good amount of blood as per the guidelines, and 2 sets of blood cultures.
Short of requiring a new transfusion.
So this is done. Kumar Aman from Jharkhand, Ranchi. In stewardship, is there any algorithm or order on specific generation of specific antibiotic, like a protocol of specific antibiotics to be maintained, like a ordered list? Or you have to start from very base dose, everything we change in antibiotic? Is there any ordered list, or we have to start from any base dose? There are 2 different questions.
No, actually, like what he meant probably was whether we have to start from a lower level antibiotic and then escalate. No, actually it depends. Your hospital will release an antibiogram based on the condition with which the patient presents to you, whether it is from community or hospital. You can decide on the antibiotic based on your antibiogram. But remember, it's just a reference. Your clinical acumen will determine the need, whatever antibiotic you have to start.
And it also depends upon the suspected site of infection.
Yes.
Yes. So suspected site from where the patient is coming, community or hospital, what is the local antibiogram, and PKPD is also very important.
And for example, even the disease will make a difference. For example, somebody with a structural lung disease like
Lung
bronchitis,
disease, like plus
and he's expected to be
yeah, for
colonized by Pseudomonas. So you might be actually going with the last resource
the
antibiotic.
risk factors for the MDROs, basically.
MDR,
Yes.
exactly.
So Dr. Tridib has a final question that the BAL, biofire pneumonia, sometimes it is very confusing. There are many bacteria coming positive, but clinically it doesn't look like that. So how to interpret it? For according to him, that viral biofire is more specific as compared to the bacterial one. Any thoughts on it?
We
No,
have
I think
covered
I
it.
think
Yeah.
I think Rajkumar, you will have the last word on this, but I think let me speak a minute on this. One thing is upper respiratory sample is different and the lower respiratory sample is different. Upper respiratory sample represents much more viruses and often likely to be false positive, if at all, or relevant or irrelevant. Lower respiratory tract in a suspected bacterial infection is pretty specific and accurate, particularly if you have gone 3, 4 days beyond the fever. And in a clinically relevant scenario, if you are sending the sample from the lower respiratory tract, I would take the classic example of a recently, freshly intubated patient, the first sample coming up. That gives you a beautiful idea of what is really happening inside that particular airway. Of course, occasional tracheobronchitis will exist. Occasional upper respiratory colonizer will exist, but more often than not, it will represent the lower respiratory tract infection scenario. Of course, if you have a valve, that is even better, but even
Yes.
an upper respiratory tract catheter sample is good enough to interpret. So it depends on,
Minimum.
once again, the right patient, right time. So the that right time is critical here, and
Yes.
right space. I'll add to that, because if I'm going to take a upper respiratory tract sample from somebody who's intubated, it will be a wrong sample, wrong site. So wrong site is also to be avoided.
So after the roller coaster webinar, final words. Nitin sir,
I think I've said almost everything.
one golden line from your side.
I have been over talking. Sorry.
One golden line. Any golden line?
I think one simple line is don't miss out on the right site. Whenever you are sampling, don't miss out on the right site, because more often than not, I see this biofire money being spent on upper respiratory sample when my infection is sitting down in the lung. That will be a sacrilege. I mean, too much money to be wasted. And order a bronchoscopy if it is needed, genuinely needed. Very frankly, I
Yes.
turned down 9 out of 10 bronchoscopies which are offered to me. So I will select one bronchoscopy in an ICU out of 10. But then when I send it, the sample is very, very accurate, because we generally are good at clinical decision making. Doctors in India are extremely well trained in their clinical experience. So I think we can go by that, definitely.
Dr. Komal?
It is difficult to establish an antimicrobial stewardship program, definitely, but it gives great results. Starting may we get some hiccups, but then once established, it is very, very useful for us, for the patients, for the hospital also. So every hospital should have an antimicrobial stewardship program, and that is my golden line.
Yeah, and even if you
Dr.
don't
Abhishek?
call it stewardship program, just get together your brains and start thinking about it on daily basis.
Yes.
Even if you don't call it, with the so-called labeled stewardship, because
Yes.
stewardship means a lot to many people. I don't have to do that necessarily, but I need to talk to all my colleagues, get their best possible help, and get the best antibiotic to the correct patient.
Dr. Abhishek?
So I think one thing that should be the takeaway from today's seminar is that we should not get bullied by the situation that the patient presents to us with. Like it's been already discussed, if a patient has come to us with a shock, that doesn't necessarily mean that we have to put him on an MROC, a meropenem, and a polymyxin B upfront. We can start with the basic empirical antibiotics, and only if there is a no response or if the cultures suggest, we should upgrade the antibiotics, and we should never be pressurized to upfront give a higher end antibiotic.
Absolutely.
Dr. Laxmi, ma'am?
Yeah, though
Your final
not now.
comments?
Yeah, though not now, by practicing the antimicrobial stewardship, definitely we'll get the glorious, healthy mankind in future. Thank you.
Thank you. Dr. Rajkumar.
What I believe is the teamwork is the secret of success. And the second point is no egos regarding antibiotics. See, usually I've seen the egos regarding antibiotics will lead to changing of antibiotics very fast. So these 2 points are very important.
Absolutely.
Thank you all. Dr. Nitin sir, Dr. Komal ma'am, Dr. Abhishek, Dr. Laxmi ma'am, Dr. Rajkumar. Antibiotic stewardship is a very important aspect that has to be covered. But rightly said, we need to look into the primary and the secondary level also in our healthcare system, because they need to get improved. With over 1,200 logins, I thank our CCI core team, Dr. N.H. Krishna, Dr. Narayan, Dr. Vijay, Dr. Ashish, Dr. Anil, for giving us this opportunity and platform to discuss such a vital part of our clinical practice. And it means to everyone. And I think with all our combined effort, we can improve this in our clinical practice. And we are seeing a great danger in the near future if it is not done timely. With this, thank you very much to all. Good night. Thank you.
Thank you.
Good night. Thank you, everyone.